To me, as a healthcare provider, as a periodontal surgeon, prevention is always the name of the game. So how can we get healthy peri-implant tissues long term? It is not just about achieving surgically successful outcomes. 80% of peri-implant disease is due to an inadequate prosthesis design. But in my clinical experience, it's higher than that. It's just to tell you that the quality of the implant-supported restoration is essential for the longevity of that implant. That means that if the implant-supported crown is of poor quality, meaning poor fit or misfit of the crown or poor design, such as rich lab restorations or over-contour, then the chances of getting peri-implant disease are much higher. Obviously, we cannot forget good plaque control, but a properly designed implant-supported crown should help maintain healthy peri-implant tissues. This is key and essential for long-term peri-implant health. This was a case that had an atrophic ridge that had to be reconstructed on the canine area. And following the principles of periosteal guided bone regeneration, we were able to reconstruct that site and place our implant. This is the final restoration. After 4 years, you can see the nice augmented site with that keratinized mucosa buccal to the implant. The provisional phase is key to push those tissues buccal and create a proper and ideal emergence profile that will match the contralateral site. So the provisional phase is key. A restoration with a poor prosthetic design, that is a rich lab restoration, that was attracting plaque, creating pressure on the augmented site and creating chronic inflammation. The patient was complaining as well. So luckily we were able to catch that on time and replace that crown for a more hygienic, ovate type of restoration with a smooth buccal profile. So you should always avoid this type of restorations. It is not just about the surgical success. Key aspect is the teamwork with the prosthodontist or the restorative dentist that can help achieve healthy, long-lasting results. In this short clinical presentation, we're going to discuss the importance of the quality of the implant-supported restoration that can lead to anesthetic implant failure. It's not just only about the prosthetic design, but as well the importance of the 3D positioning of that implant. So we're going to showcase a number of clinical cases showing the different possibilities that we can see when we find this type of restorative and implant aesthetic related failures. This may or may not be associated with biological complications and peri-implantitis. As you will be able to see, some patients are simply not susceptible to periodontitis and peri-implantitis, but a poor prosthetic design will inevitably lead to anesthetic failure that may or may not be associated with peri-implantitis. These cases were referred to me to see the different options of treatment. This is another individual that had that implant placed over 16 years ago. This is one of the common patterns that we see on anterior implants because of the slow jaw growth that we can, that some individuals, some adults have throughout their lifetime. See oftentimes a discrepancy in the mucosal and gingival margins of central incisors. When a central incisor has been placed many years ago, slow growth of the jaw may lead to this type of discrepancies, which oftentimes are difficult to resolve. The patient had pretty good plaque control, but there are definitely some issues, some trauma-induced gingival recessions as well as mucosal recession around that implant. So again, we have a combination of factors here. First, the jaw growth, then the prosthetic design. We can see an over-contour restoration with open margins, and basically trauma-induced recessions over the implant and the adjacent teeth are basically the result of years of brushing incorrectly on those areas. Individuals don't necessarily need to develop peri-implantitis or mucositis, but definitely will develop basically an aesthetic failure as a result of we have a number of factors again, and one of them, implants placed on that central incisor, is a bit too fat for me. I like to place smaller diameter implants, 4 millimeter for anterior for central incisors, and 3.5 for a lateral incisor. That will reduce the risk of bony dehiscences on the buccal aspect. A different case, I mean, this is just two different type of scenarios that we may encounter in private practice. I mean, it is not just only about the prosthetic design, but of course the 3D positioning of those implants. And when we have all those factors combined, we may encounter this type of complications. On top of that, again, the patient may be susceptible to develop peri-implantitis, especially if they had history of periodontal disease, which seemed to be the case. These implants were placed over 9 years ago, and the patient was referred to me to evaluate the ongoing inflammation and suppuration that you can see on the buccal aspect. The truth is that a restoration with pink porcelain over several implants may not be the best option to have good plaque control. And at this stage, we are basically speculating on what happened here. When did the process of peri-implantitis started? Taking the pieces of the puzzle together, number one, those implants were placed to buccal, hence the need for a pink porcelain, which may not have favored good plaque control, especially under the pontic area. We don't know if the patient had what type of augmentation, if any, was done, but the truth is that there is severe bone loss on all the implants, more visible on the implant, on the lateral incisor implant on the right area. All in all, again, this is a combination of the perfect X-Storm implants placed to buccal with poor prosthetic design, and on top of that, a patient susceptible to peri-implantitis and trauma-induced gingival recession as well. Those implants were recommended to be removed, which was done later on. This is a more simple case. The chief complaint was not only the aesthetics. The patient had that implant placed again many years ago at the lateral incisor area. The margin is visible. Again, this is because of poor implant 3D positioning and perhaps lack of bone augmentation. The clinical signs, so again, the implant with an exposed metal margin, the trauma-induced mucosal recession that probably happened at some point after the implant was placed years ago. The chief complaint, nevertheless, is not only aesthetics, but pain and palpation, especially on the apical area of that implant. So we have, again, two main chief complaints with pain and palpation. It is quite common to see, especially on the anterior maxilla, quite common to see a concavity that, if not treated or if not properly treatment plan at the time of implant placement, we see basically perforations at the apical aspect of that when the implant was placed that may develop symptoms such as, in this case, pain. So we need to address two main issues. We decided to eliminate basically do a kind of an apiectomy, eliminate the apical portion of that implant. We were able to save the implant in this case. The apical aspect had to be grafted, which in this case was a combination of autogenous bone, a connective tissue graft on top to correct the gingival recession, the mucosal recession at the implant site. The variety of the cases that we can find, some may be more difficult to resolve than others, but the combination of different aspects may lead to the aesthetic failure of those anterior implants, especially when the positioning, the 3D positioning, is not correct. So a different case, this is a patient that was treated by a different periodontist for severe periodontitis. Well, in this case, not only the implant was placed to buccal, the site was not properly augmented. So as a result, the implant is basically showing a super long implant crown, not aesthetic, with a lack of keratinized mucosa, and But again, another case depicting poor treatment planning as a result of lack of augmentation. In this case, the recommended treatment was to implant removal and augmentation of the site for future implant placement. Again, a different case scenario. We see generalized inflammation with localized deep pockets on not only the implants, but some of the teeth. Patient with past history of Peri-Implantitis. Implants were placed elsewhere. The chief complaint was pain on the at the implant size on the left side, canine area, aesthetic failure as well. Common mistake to place two implants too close together on the aesthetic zone, especially if the implants are poorly placed or too buccal. It is going to lead to this type of aesthetic failures and complications as well. So we have a combination of deep pockets, poor prosthetic design, poor 3D implant positioning, and all in all, poor treatment planning. The advice was to remove the implants. You see also the adjacent crowns on the teeth present a significant amount of inflammation, open margins, and bleeding upon probing. The implants were removed, and you can see the tremendous angulation of those implants, at least 30 to 40 degree buccal misangulation, which led to this type of implant restorations. So this is one of my cases. I placed an implant for the central incisor, and after augmenting the site, everything was going well. But when I saw the patient for follow-up, I noticed that there was a huge ridge lab on that implant supported restoration on the central incisor, the right central incisor. So my recommendation was to remove immediately that implant supported restoration because it had a huge ridge lab that I know with time will cause chronic inflammation. So this is just to tell you that the importance of the follow-up on our patients is not only about surgical excellence, but we need to follow up on those implant crowns, make sure that the prosthetic design allows for cleansability. Again, my recommendation for these anterior implants is definitely always go for an ovate type of restoration, avoid ridge lab restorations. There is a number of current research has been published, and these are some of the publications that you can read. Definitely the prosthetic biological connection and its influence on peri-implant health is key. Again, I cannot emphasize enough the importance of the, especially at the buccal aspect of those anterior implants. Ridge labs will inevitably attract food and plaque, does not allow us to properly probe the implant and assess areas of inflammation or pocket formation. So definitely always avoid them and use a smooth profile ovate type of pontics. I want to finish by saying that it's not all about surgical performance or placing the implants on the ideal prosthetic position. It's a combination. This is a teamwork. The surgical aspect is key, as well as the prosthetic aspect. The quality and the design of the implant supported restoration can have definitely a significant impact on the peri-implant tissue health and aesthetics, of course. Depending on the complexity of the case and the amount of bone loss, we may or may not decide to remove the implant and start all over again. Unfortunately, many of these cases that I see these days require implant removal. Both from the surgical aspect and the prosthetic aspect need to work together to deliver excellence and achieve good, stable aesthetic results.